In the United States, insurance companies, even in Canada for secondary insurance, they say if we don't have the DSM, what do we have? And they get scared, and they know that it's a mess scientifically, but they want to have something that they can go by. I actually have a solution for that, which is what we are in fact doing and have been doing for decades now is we're saying if you have the right kind of degree, then if you say the patient has X and needs this, then we'll say, okay, if that fits our guidelines, even if we know that there's no scientific basis. So why not just be upfront and instead of saying, go by the DSM, say, if you have the right degree and you think this person will benefit from a certain kind of thing, then we'll go along with it, because that's what we're really doing anyway, right? Okay, so the insurance companies, the government, because in the States, Medicare and Medicaid are rooted in the DSM for psychiatric treatment, for mental health treatment. The American Psychiatric Association, of course, and the DSM, the drug companies, very powerful at wanting to maintain this whole system. So those are some of the factors. And then for the individual, the fact that the average North American worker is working vastly higher numbers of hours per year, so everybody's busy, so they want quick solutions. The fact that we live in a very psychiatrized and psychologized society, so instead of thinking, this person's lonely, or this person doesn't get any vacation time, or whatever, we think, oh, diagnosis, drugs, maybe a little psychotherapy. We don't think about meditation, exercise, nutrition, friends, whatever happened to friends being helpful and protective. I hear friends all the time say, well, her boyfriend broke up with her, but I didn't talk to her about it because I'm not a therapist. So we're professional, or somebody, somebody died, somebody lost somebody through death, and they're feeling horrible. Send them to a therapist. Well, no, that's what your community is supposed to do for you. I'm not saying there's not a place for therapy, and I'm not even saying there's never a time to use a psychotropic drug, but these are the two default kinds of approaches, and there's a whole huge range. I wrote the chapter on emotions for the current Our Bodies, Ourselves, and we were talking about this huge range of other things that people don't think of. And individuals assume that what the experts are telling them is the truth and is scientifically grounded. And so they think they need a diagnosis and a pill and maybe some psychotherapy. And they think, I feel better when I swim 3 times a week, but surely that can't be what I need.
Well, in fact, you have written at some point, I think it was in the Bias in Psychiatric Diagnosis book, you have written, in principle, psychiatric diagnosis can be helpful also, in the same way that accurate physical diagnoses can be. So you're not in fact saying every turn psychiatric diagnosis is unhelpful, but it sounds like you've come to really question the whole process on which those judgments are made, and pointing out and highlighting the harm that those labels do to how people think about themselves.
Oh, they do tremendous harm, and I've written about this a lot of different places. But there's one other thing. I want to make it clear that when I say that in principle psychiatric diagnosis could be helpful, I don't think in practice it is. Virtually ever.